Welcome. As we mentioned earlier, we divided the Antimicrobials lectures into 2 lectures, and this is the second of 2. So with that, let's get started. In this second lecture, you see the list of antimicrobial agents which we are going to be covering, including briefly touching on the aminoglycosides, spending a little bit more time on the sulfonamides since this class is one that's commonly prescribed in primary care. We'll introduce you to the oxolidinones, or actually oxolidenone. There's only one agent in this class at present. Touch on some miscellaneous antibiotics such as clindamycin, metronidazole, and nitrofurantoin, and discuss antifungals and antivirals as well. I wanted to briefly touch on the aminoglycosides. The text doesn't discuss them in detail, and the reason for that is they're typically used in the acute care setting, not in the ambulatory setting. However, if you're monitoring a patient, or if you have a patient that comes to see you after receiving an aminoglycoside, it's important to recognize that there's some pharmacokinetic dosing involved, and therapeutic drug monitoring is required. So drug levels should be followed on these patients, and subsequent doses should be adjusted for the patient's size and renal function. The reason I wanted to bring up this class, which includes agents such as gentamicin, tobramycin, and amikacin, is because they can result in some nephrotoxicity. The highest risk of nephrotoxicity with these agents are with prolonged use, so greater than a week, as well as if the patient is on another agent that can also be nephrotoxic as well. So with that, it's an important monitoring piece to follow the renal function and drug levels in any patient that you prescribe these agents to. Now, certain of these agents are available in topical and ophthalmic preparations, and considerations are not a concern in those types of preparations, and we'll discuss that when we touch on topical agents further on in this course. These agents can also result in ototoxicity due to damage at the 8th cranial nerve. Shifting gears to the sulfonamide class, you can see they do have a wide therapeutic role and are often used in primary care, as their indications tend to be primary care type visits. So we can use these agents often to treat urinary tract infections, ear infections, traveler's diarrhea, and sinusitis. They are bacteriostatic, and now we're going to just talk briefly about how they work. I think it is important to understand how agents work when you're prescribing them. But you may recognize the name para-aminobenzoic acid back from chemistry or biochemistry days. It's abbreviated PABA, and sulfonamides actually share a very similar structure to para-aminobenzoic acid. Microorganisms require this in order to form dihydrofolic acid, and this pathway is needed for forming bacterial nucleic acids, the building blocks of their DNA, RNA, and proteins. So the sulfonamide class inhibits this step by mimicking the para-aminobenzoic acid. So basically it's kind of in disguise, and it incorporates itself in so that the bacteria then no longer can form viable nucleic acids. Again, touching on the important pharmacokinetic aspects of sulfonamides, as with many of the other antimicrobial agents, absorption is agent-specific. Some of the sulfonamides are more rapidly and readily absorbed than others. They do have a wide volume of distribution, and they all have some element of hepatic metabolism. Regarding elimination, the parent drug and inactive metabolites are excreted renally. For this reason, with the sulfonamide class, we typically have to dose reduce in patients with renal dysfunction. I have here versus choose a different agent. These agents can result in some nephrotoxicity. Typically, my recommendation would be if you have a patient with mild renal insufficiency, dose adjust and give them their short course of a sulfonamide to treat their urinary tract infection, etc. If you have somebody who is more severely compromised but not yet on dialysis, it may be prudent, if you're going to need to use an agent, to use a different agent. So kind of take the patient scenario and degree of renal dysfunction, as well as what you're treating and how long the course will need to be, to decide whether you should dose reduce versus try to choose a different agent to treat your infection. The sulfonamides have some important counseling points that you should touch on with your patients. as with some of the other antimicrobials that we spoke about in the first lecture, they too have photosensitivity reactions associated with them. So please counsel your patients who are fair-skinned or prone to burn to use proper protection against the sun if they're going to be outside. As far as gastrointestinal side effects, many of these agents are ideally taken on an empty stomach, but it's typically okay to dose them with food if the patient has a GI upset resultant from the antimicrobial. One thing that's very important is to make sure that your patients drink adequate amounts of water to prevent crystalluria of these agents. So you want to make sure that you counsel your patients to drink their 8 glasses of water a day, especially while they're on these agents. And given that many times you're prescribing sulfonamides for a urinary tract infection, that increased hydration has multiple benefits, not only preventing the crystalluria. You want to use caution for this reason in prescribing to patients on diuretics who may not be able to maintain adequate hydration or who may not be able to have the amount of fluid that they would need to prevent the crystalluria. So again, just a caveat when you're prescribing these, something to think about. Blood dyscrasias have been seen with sulfonamides. They're very rare, but when they occur, they can be fatal. And for this reason, they're contraindicated in patients with G6PD deficiency. How this may present, so these are the things that you're looking for your patient to complain of, is jaundice, purpura, and sore throat. So if you have anybody call you after prescribing these medications thinking along the lines that blood dyscrasias are very rare, so it might just be that their infection's not getting better yet if they still have a sore throat. However, something to keep in the back of your mind what your threshold would be for having them in to check a blood panel. Linezolid is the only member of the oxalidenone class, and say that 10 times fast and see how often you can say it correctly. Good luck. Really where we see this agent used, and it is an oral or IV agent, is in the treatment of methicillin-resistant Staph aureus and vancomycin-resistant enterococcal infections. How linezolid works is through binding to the 23S ribosomal RNA of the 50S subunit, and that's a lot of detail, but really what it's doing is, again, preventing bacterial translation and replication, interfering with protein synthesis, and thus making a bacterial cell that's no longer viable. And you can see the pharmacokinetics of linezolid listed for you here. It does have complete and good PO absorption, so it makes it easy to give in oral form. About 30% is protein bound, and it does distribute into well-perfused tissues. It's oxidized by the liver, and about 1/3 of it is excreted unchanged in the urine. Before discussing the 2 bullet points listed on this slide, I wanted to take a minute and again remind you that when you're prescribing this agent, it's often going to be for a resistant infection. So you need to have a threshold of when to bring an infectious disease specialist into the mix when you're using agents like this. These agents should not be used to treat methicillin-susceptible Staph aureus on a regular basis unless you have a patient who has an allergy profile that dictates otherwise. The rationale behind this again stems back to issues with antimicrobial resistance. We want to use the most narrow agent to treat the infection that will still be effective. So when you're pulling out linezolid from your antibiotic arsenal, please do so with judicious prescribing habits. In discussing some adverse reactions that have been seen with linezolid, on the more mild to moderate level, you see kind of a typical antibiotic reaction profile with nausea, vomiting, diarrhea, and some patients do complain of headache. But there are a couple of reactions that are more severe. Myelosuppression and neuropathy have been seen in patients on linezolid. It's typically been associated with longer courses, so courses of greater than 2 weeks of therapy. Some practitioners supplement with pyridoxine or vitamin B6 if you're anticipating a long course. I think the rationale behind that is just to help prevent the neuropathies associated with long-term linezolid. And really, if you think about it, giving someone a vitamin B6 supplement is not costly, and it's probably not going to do any harm. So given that, it's something to consider if you're going to be prescribing a long course. and you may see some infectious disease specialists doing that routinely. One thing that often goes under-recognized about linezolid is the fact that it is a monoamine oxidase inhibitor, and there's varying literature out there regarding the drug-drug interactions with antidepressants and other agents that depend on monoamine oxidase for metabolism. So it should be used with caution in patients on these agents, and many references will direct you to discontinue the interacting agent, especially true monoamine oxidase related or metabolized drugs. SSRI data is a little more fuzzy, I would say, to describe it. Many practitioners do choose to discontinue the SSRI when you're on linezolid, and in fact the packaging, the package labeling does suggest this. You want to monitor your patient for signs and symptoms of serotonin syndrome. There is a drug-dietary interaction with linezolid for the same reason, because of the monoamine oxidase inhibition, so you want to make sure to counsel your patient on this, so avoiding foods that are high in tyramine, like some cheeses, beers, wines, etc. It's not that a diet has to be completely tyramine-free, but if you do notice that your patient is eating tons of food that has high tyramine content, please counsel them appropriately to decrease their tyramine intake. Clindamycin is an agent that's been around for quite a long time, so many of you probably have experience with this agent. Its mechanism of action is, again, inhibiting protein synthesis. It's the same thing that macrolides are doing. It's binding to the 50S ribosomal subunit of organisms, causing protein to not be formed and thus losing cell viability. A little touch on its pharmacokinetics. It's highly protein bound. It's got a very large volume of distribution. However, given that, it does not penetrate into the brain or CSF well enough to use this agent for a CNS infection, so it should not be prescribed for infections of that type. Clindamycin is typically prescribed for its strong anaerobic coverage, but it does cover mixed infections as well. You'll oftentimes see it as part of aspiration pneumonia protocols or used to treat abscesses due to staphylococci, because clindamycin does penetrate abscesses quite well. Regarding counseling and monitoring for your patient on clindamycin, probably the most associated or frequently associated side effects are the GI type of nausea and vomiting and diarrhea. One thing, though, you want to make sure to monitor, especially, again, in elderly patients or patients on prolonged courses of oral clindamycin or IV clindamycin, is for antibiotic-associated colitis. So if you have a patient who contacts you who seems to have very severe diarrhea or bloody diarrhea, that should trigger you to have them come back into the office and reassess whether or not it could be due to the clindamycin. And it's something more serious than just the little bit of diarrhea that most patients can expect to have from clindamycin therapy. Another antimicrobial agent that's frequently used for its anaerobic coverage is metronidazole. While the mechanism of action is not well understood, it does interfere, again, with bacterial DNA synthesis. Metronidazole penetrates well into tissues, and it does cover certain gram-positive and gram-negative organisms as well, but typically its niche is used as an anaerobic coverage antimicrobial. It's often prescribed in primary care, and it can be used orally or topically to treat bacterial vaginosis. Another indication that you may see it used for in primary care, and may prescribe it yourself, is for trichomonal vaginitis, and it's important to remember to treat both partners in this case. Metronidazole can be used to treat Clostridium difficile infections and other gastrointestinal related infections due to its good anaerobic and some gram-negative coverage. And I've listed for you here a few counseling and monitoring points to consider when you prescribe metronidazole for your patient. One important one is the disulfiram reaction. And for those of you who aren't familiar with that reaction, what it is essentially a pretty significant nausea and vomiting that can be associated if someone takes metronidazole with alcohol or any sort of alcohol source at all. And where patients sometimes get fooled is in using over-the-counter medications that may have a high alcohol content. Some of the over-the-counter preparations for cough and cold contain a significant amount of alcohol to help keep medications in solution. So when counseling patients to avoid alcohol on metronidazole therapy, please also have them check their over-the-counter medications, and if they aren't comfortable doing that, please have them check with their pharmacist on whether or not what they're taking contains enough alcohol to cause a disulfiram reaction. This being said, it can occur with both oral and topical or vaginal metronidazole, so patients on metronidazole of any form should be counseled to abstain from alcohol. Conversely, if you have a patient who you know will not be able to abstain from alcohol, using metronidazole as an antimicrobial may not be the best option if you have another choice to use. Metronidazole should be adjusted in severe hepatic disease, mild to moderate disease, not something to worry about. It can cause some gastrointestinal upset, and in some patients it may cause a darkening of the urine, but really this isn't of high concern unless the volume of urine decreases so that it's a darkening due to dehydration and concentration versus just the drug. So if they call you up and they state that they do have darker urine, ask them how frequently and how much they're urinating and assess urine volume. And if that's okay, it's really not anything to be too concerned about. And speaking of urine, we're moving on to an agent that's used exclusively to treat urinary tract infections, and that being nitrofurantoin. The reason it's used only in UTIs is that that's really the only place where it achieves therapeutic concentrations. Its mechanism of action, again, is on the ribosomal level. It inactivates the bacterial ribosomal proteins, and unsurprisingly, it's excreted through the kidneys, so that's why it gets such great urinary concentrations. Given this, though, it's not recommended to be given to patients with a creatinine clearance of less than about 50 to 60 mils per minute. And the rationale behind this is it can accumulate, and it does lose its effectiveness because it's not being delivered to the site of action. And if it accumulates and isn't effective, really the only thing that we're increasing for our patients is a risk of toxicity and therapeutic failure. So if you have patients with renal insufficiency with a creatinine clearance of less than 50 mils per minute, it's probably not the agent to treat their UTI. If this is the only agent you have left in your susceptibility pattern, however, you may use it and then just monitor for toxicity and follow up with a repeat UA at the end of the course to make sure that you have eradicated the infection. We are seeing some urinary tract infections now, especially with patients from nursing homes that have very limited susceptibilities. So we do, in some cases, use this in patients with renal insufficiency, even though under other circumstances, it's not the best choice. We're going to shift gears now and briefly touch on antifungals. Now, antifungals in general could be a whole separate talk, but for the purposes of this course, we'll focus on their use in primary care, not necessarily prophylaxis or treatment of severe life-threatening invasive fungal infections. Most of the antifungals used in primary care are the azole antifungals, and their therapeutic roles I've listed for you here. So treating mild candidiasis, such as vaginal candidiasis or cutaneous candidiasis, tinea infections, onychomycoses, systemic fungal infections, again, typically in combination or step down from more aggressive intravenous therapy when a patient is stabilized into a maintenance phase. And those systemic fungal infections should be treated in conjunction with an infectious diseases or pulmonology specialist. We have seen the azole antifungal use for prophylaxis and treatment increase over the years. And whenever you increase the widespread use of an agent, usually resistance or selection out for resistant pathogens then follow. Now, in the community setting, in a patient who's never received an azole or may receive them extremely sporadically, it's probably not something that's going to be of concern. But if you have a cancer patient or an HIV patient or any other condition where they've been on chronic azole prophylaxis and suddenly you have something pathogenic growing out, oftentimes it won't be that nice little friendly Candida albicans strain. Rather, it'll be a more resistant strain such as a Candida glabrata. So things to keep in mind is knowing whether or not your patient whom you're prescribing for is experienced with azole antifungals, or if they're treatment naive or have just received them every now and then sporadically, for example, for vaginal candidiasis. Again, these agents reduce ergosterol synthesis by inhibiting the fungal cytochrome P450 enzyme. So here are agents that are actually working on fungal P450 enzymes. How this works and how they don't act on our P450 enzymes is they have a greater affinity for that fungal enzyme versus our enzyme. However, that being said, there's still plenty of cytochrome P450 drug interactions in humans. This table summarizes the difference in pharmacologic properties of the available agents. Of note, if you're getting to the point of needing to use voriconazole or posaconazole, which are more broad-spectrum azole antifungals used to treat resistant infections or fungi that typically are associated with more serious infections, I'd again be doing so under collaboration of an infectious disease specialist. But you can note in this table some of the differences in absorption, half-life, and elimination of the agents, and thus some of the niches that they may have, or in certain cases, reasoning behind once or twice daily dosing due to the half-life, or whether or not we have to adjust them for renal dysfunction. The take-home point, though, is given that cytochrome P450 issue that we discussed a little bit ago, it's important to look up drug interactions when prescribing these for your patients, or collaborate with a pharmacist to help you screen for interactions, as some of these interactions can have a quick onset and result in significant potential for harm to your patients. So please be aware that when prescribing azole antifungals, drug interactions should be at the forefront of your brain. Liver function tests in patients need to be assessed prior to starting and throughout the course. I'll caveat that off by saying if you're just using a short course in an otherwise healthy patient, it's probably not necessary to do so. But if you have someone with comorbid illnesses, other medications that are hepatically metabolized, or you know you're going to be putting your patient on a prolonged course or prophylaxis dosing of these agents, it's probably a good idea to keep an eye on their hepatic function. Azole antifungals should be avoided in pregnant women and nursing mothers. Another key point is that elderly patients are often more susceptible to the hepatic effects of the azoles, so they may be a population that you might want to keep an eye on their liver function if you're prescribing them a longer course of azole antifungals. The elderly often, due to advanced age, have diminished renal function as well, so for this reason you'll often need to dose adjust down when prescribing azole antifungals in this patient population. Now we're going to shift gears altogether again. We have already discussed antibacterials and antifungals, and now we're going to shift to antivirals. We're going to start by discussing the antivirals used to treat and prophylax against influenza virus. There's two classes available, the adamantanes and the neuraminidase inhibitors. In the adamantane class are amantadine and rimantadine, and in the neuraminidase inhibitor class are zanamivir and oseltamivir. The adamantanes specifically inhibit replication of influenza A viruses, but not influenza B viruses. Historically, we hadn't been as concerned with influenza B as it's a less nebulous virus. It usually doesn't knock you down and have the serious ramifications that an influenza A infection can have. The adamantanes work by interfering with influenza A virus M2 protein. So again, you see a common theme with these medications targeting protein production. What this does is inhibit viral uncoating and replication, and also decreases viral shedding. There are some significant adverse reactions associated with amantadine and rimantadine that we'll discuss on this slide. Of course, as with almost any antimicrobial, antifungal, antiviral, you're going to have some GI side effects. And with these agents, however, it's often due to the anticholinergic effects of the agents. Along that line, you see the anticholinergic CNS effects as well. Due to the anticholinergic nature of this drug, amantadine in particular has been used to treat movement disorders or early Parkinson's disease. And on the next slide, we'll discuss why we really aren't seeing these agents used for influenza anymore. So chances are, if you see this on someone's medication profile, it's being used for the movement disorder indication. However, that doesn't mean we don't need to monitor for the anticholinergic side effects such as dizziness, gastrointestinal slowing of motility, dry mouth, visual changes, etc. These are teratogenic, so again, please avoid them in pregnant women and women trying to become pregnant. And there are some psychological side effects as well. There's been cases of worsening mental illness in patients on these agents. So anytime you start one of these, you should be monitoring if your patient has a history of mental illness. I mentioned that we don't use amantadine and rimantadine for influenza at present, and this is the reason why. And the CDC has issued a warning, and basically what this warning says is that many of the circulating influenza viruses in the U.S. have developed resistance to amantadine and rimantadine. And for that reason, with good confidence, the CDC can't recommend their use to treat or prophylax against the circulating influenza viruses. Now, they do ongoing surveillance, and if that would ever change back to a point where we are seeing increased susceptibility to these agents again, my anticipation would be that they'd release another statement stating that we can go ahead and use these. But for now, amantadine and rimantadine should not be used to treat or prophylax against circulating influenza viruses in the U.S. due to increased resistance. So if we can't use the adamantane class for influenza, that leaves us with the neuraminidase inhibitors. The neuraminidase inhibitors have activity against both influenza A and B, and as we discuss their mechanism of action, you'll see why. But they're creatively named the neuraminidase inhibitors because they inhibit viral neuraminidase. And what this neuraminidase then does is cause a viral aggregation at the host cell surface. And so if we're inhibiting that, we can reduce the number of viruses released from the infected cell. Since this enzyme is common to both influenza A and B, that's why the neuraminidase inhibitor class is active against both types of influenza. The two available neuraminidase inhibitors are listed for you here on this slide. The first, zanamivir, is marketed under the brand name Relenza, and it's an orally inhaled powder drug. It's currently approved for the treatment of influenza in persons greater than or equal to 7 years old, and also approved for chemoprophylaxis of influenza in persons greater than or equal to 5 years old. One thing to be considered with this agent, since it is an orally inhaled powder drug, your patient needs to be able to manipulate and use the inhaler device correctly in order to receive benefit from this medication. The second agent is oseltamivir, marketed under the brand name of Tamiflu. Oseltamivir is available in a capsule or oral suspension form, and it's indicated for the treatment of influenza in persons greater than or equal to 1 year old, as well as chemoprophylaxis of influenza of persons greater than or equal to 1 year old. That being said, in 2006, Roche and the FDA notified healthcare professionals via a MedWatch bulletin. And for those who aren't familiar with MedWatch bulletins, they're safety bulletins that are issued by the FDA anytime there's a concern with a drug or device or anything monitored by the FDA. If you would like to subscribe to the MedWatch listserv, you can do so by going to the MedWatch or FDA MedWatch website. Anyway, back to the bulletin that was issued on oseltamivir. Basically, they mentioned that in children, they were seeing post-marketing reports, mostly from Japan, of self-injury and delirium with the use of Tamiflu in patients with influenza. So they advise that people with the flu, particularly children, may be at an increased risk of self-injury and confusion shortly after taking Tamiflu, and therefore should be closely monitored for signs of unusual behavior. If they saw any sort of unusual behavior, they encourage parents to contact a healthcare provider immediately if the patient taking Tamiflu started behaving strangely. So if you do prescribe this to children, please make sure to counsel their parents appropriately that any sort of behavior change should be discussed with you. Now, one interesting point about these medications is that in order for them to be maximally effective, patients really need to present to you at the right time, within their quote-unquote window of opportunity. If used within 48 hours of illness onset, both drugs decrease viral shedding and decrease duration of influenza symptoms by about 1 day when compared with placebo. Now, I think an important thing to mention is that decrease in viral shedding, so decrease in risk in spreading to household contacts. However, you do note that you only see a 1-day improvement, if you will, with these medications versus placebo. So from a cost-benefit standpoint, it's probably more so for the decrease in viral shedding versus the actual patient outcome in course of influenza. With regards to adverse reactions, both of these medications have some GI side effects with them that your patients should be counseled to expect. And for zanamivir, you should avoid this agent in patients with underlying pulmonary disease because it can precipitate bronchospastic reactions. As primary care providers, I think it's important for you to keep abreast of the latest CDC recommendations for the use of neuraminidase inhibitors and all other antivirals for treatment and prophylaxis of influenza. I've listed the CDC website for you here, and that's updated very frequently. The recommendations come out on an annual flu season basis, and it also includes information regarding flu vaccination. And with that, treating influenza is not a substitute for vaccination. So you should be screening your patients, and according to CDC risk strata, vaccinate all of your patients appropriately. We're going to very briefly touch on antivirals used to treat herpes virus infections. I have 3 listed for you here that are commonly used: acyclovir, valacyclovir, and famciclovir. It's important for you and your patients to realize that herpes treatment is suppressive, not curative. So we're never going to eradicate the virus from the bloodstream. We're actively trying to avoid flares for the patient, or treating active flares, depending on whether you're using these prophylactically or for treatment courses. They work by basically attacking a viral enzyme, viral thymidine kinase. And what the virus has done to outsmart these agents in some cases is lack this enzyme. So again, if we don't have a target, we're not going to have any sort of impact. What this does then is inhibit the DMA polymerase, and viruses can't form adequate or functional viral DNA. So again, a lot of our mechanisms of actions for antimicrobials in general have to do with attacking protein synthesis or DNA synthesis, really breaking down the structure backbone of the virus or of the bacteria. For the purposes of this course, we're not going to go into detail the treatment guidelines for herpes, but you can find them in the STD treatment guidelines published by the CDC, along with guidelines to treat other sexually transmitted infections. These guidelines are often updated due to changing resistance patterns, so rather than review it in this course, I think it's more important for you to know where to find them so that when you need to, you can get the most updated version. And with that, I'd like to thank you for your attention over the course of this second lecture on anti-infectives, and remind you to please post any questions that you may have about the content of the lecture, or if anything wasn't clear, or any of the additional required reading or text materials on the Ask the Pharmacist link for this module. Thanks very much.